Good morning, everyone. For those of you who don't know me, my name is Lorraine McDonald and I'm McDonald Development Manager for the area and the lead with Helen, Programme Manager for this piece of work. What I'm going to do this morning is to give you a little bit of a background and to put things into context, and then Helen will talk more about the scoping and where we are to date. So I wanted to start off by giving you an opportunity, for those of you who aren't aware, is that Macmillan Cancer Support has 9 Macmillan outcomes. Now these 9 Macmillan outcomes were statements that were the end result of talking to patients and carers, talking to Macmillan professionals, by talking to colleagues and people who work within Macmillan, to say, well, if you had a cancer diagnosis, what were the things that would be most important to you to receive the care that you would like through that experience? When you look at these statements, what you'll say, well, actually, they're not rocket science. However, this is the thing that will underpin the whole of Macmillan's strategy. Now, when I go through the statements, what you'll say is that well, we're actually doing this, we work in healthcare and this is something that we're doing. So what I'm not saying is that Macmillan has come up with some fantastic idea that actually nobody else has thought of, because a lot of you across different disciplines and within health and social care will be working towards all of these statements. What I will do is read through them because they are pertinent to all patients who have a cancer experience. But I want to start off by actually the central one, which is I am treated with dignity and respect. Me being here, following on from Ali and her story, is really what I would say is very inspiring and quite overwhelming, really, because Ali, you've talked about your personal experience, and you've stood up here very much in a very dignified way, and we understand what your experience has been like. But the thing is that fundamentally what is important to everybody, you know, we all want to be treated with dignity and respect. So I want you to focus on that aspect to begin with, because the whole core of what Macmillan does and Macmillan's strategy is that all of our services should be informed and actually work with the patient with co-creation, and the fact that if we listen to the patient's story, then we can help improve what their experience is. And when I'm talking about the patient, I'm also including the carer and the other people, their family, who are significant to that individual. So we start at the beginning. I was diagnosed early. I understand, so I make good decisions, and this is really important. Ali, you talked very much about the fact that information and support was fundamentally what helped you through your experience. I get the treatment and care which are best for my cancer and my life, and obviously we all want that to happen. Those around me are well supported. What patients tell us that is fundamentally so important to them is that their husband, wife, mother, son, daughter, aunt, uncle, whoever, are well supported. And certainly a lot of the work that Macmillan is doing is to try and support the significant person in that, in the patient's life. As I said, I'm treated with dignity and respect. I know what I can do to help myself and who else can help me. And that again focuses on the fact that some people would like to be signposted to certain services, and Ali, again, you talked about the importance that information has, access to welfare benefits. If you have children, it might be about working with a social worker, it might be about access to the allied health professional team, so it can be a multiplicity of lots of different things, but people need to be signposted to those services. And significantly, certainly with brain tumours and central nervous system tumours, we know that people forget things, so sometimes we have to reiterate and give that information to people. I can enjoy life. Doesn't everybody want to have the opportunity? And you talked very much about how you adapted your life, Ali, in the way so that you can enjoy things. I feel part of a community and I'm inspired to give something back. Part of the reason that that is there is because people have told us that they've done different things for us, they've volunteered. One of our biggest fundraising events is the Macmillan Coffee Morning, and people have told us, well, if you come back to me and ask me to do something, I'll do that for you. And people are very inspired. Ali, you're an example of that. People want to tell their story because they want to make a difference in other people's lives. Family carers, they tell their story. You know, people climb Kilimanjaro, they cycle across China, they do lots of different things. But what we try and do is provide that opportunity for people. And I want to die well. Now, we'll hear presentations today from different people who are looking at helping to support all of those things. One thing that I would say though is that if you talk to patients, they will have different experiences. Some people will be able to say yes to some of these, some people will say no. But what we want to do is to know that by 2030 that everybody would be able to say yes to all of these things. So what are the aims of today? Well, we want to share the experience of the patient within the pathway. We want to tell you more about the scoping exercise and what we've found out to date. We want to share professional understanding of what's working well and where there is potential for improvement. And I don't want us all to sit here to think, well, Macmillan's got all the answers and we're here to criticise what's going on, because you will hear of really, really excellent examples of what are happening across the patch. But the thing is that sometimes there might be access to something locally that isn't available in another rural area, so maybe North Yorkshire might not have what we've got in Hull. So it's an opportunity to build on that and to spread that across the area. And we want to start to shape and commit to a future work programme. There are different people here who are from the different clinical commissioning groups. We want to engage with local authority, we want to engage with the clinical teams, and fundamentally we all want to work together, and there's a real passion for that to actually happen. Very quickly, I'll give you a bit of background. This was a vision that came really from me being able to sit at the Cancer Network Board and hear that there were things that people across the area, the commissioners, wanted to look at in relation to brain tumour and central nervous system cancer. And the thing about it that was an opportunity for Macmillan is that this is part of a national programme of redesign and service improvement. And so there are different examples across the area, UK-wide, of where people are working together to look at different pathways. However, this is the first programme within Macmillan where we're looking at a rare and complex cancer. And what we hope is that there will be learning from this programme of work that potentially can be transferred to other areas around brain and central nervous system, but also it might help us with decisions around some of the more complex cancers. Maybe an example would be sarcoma. So what can we learn and what can we transfer? Fundamentally, the whole of this is that it's about patient and carer consultation and co-creation of services with the patient, with clinical teams and with commissioners. It's about that being a shared vision. And what I would say is that the programme provides us with the opportunity to look at what the challenges are along the whole of the pathway, and that's, as I said, from diagnosis through treatment, living with the effects, survivorship and end of life. And what we want to do is build on what's already in place. Now this is a slide that actually shows you the Berlin Wall before it actually came down. And what it is here is to illustrate, and I've stolen this from Jane, who is our chair for this afternoon, in that what we want to see is that the redesign and the improvement, the service improvement, looks at the whole of the pathway. But the thing that's fundamentally important for the patient is that there are significant effects in the transition points. And what we will hear about today, and what often is a problem for the patient, is actually that it's at times of transition, you know, from after diagnosis is made and treatment is given, after treatment has completed and the patient goes home, then what happens? You know, what does that mean for the monitoring of that person and their experience? So what we would also say is that the redesign actually looks at 3 different aspects at least across the whole of the pathway. So in preparation for this, I was able to be involved in making a presentation to what was then the Humber and Yorkshire Coast Cancer Network Board, and later became the North Yorkshire and Humber Clinical Alliance, and took that vision of the idea of looking at the brain tumour and central nervous system cancer pathway and what that might mean. There was initial agreement from North Yorkshire and Humber Clinical Alliance and partner commissioners and provider organisations that there was an opportunity to focus on this pathway and look at redesign and service improvement around that. And the Commissioning Support Unit has also taken this to the collaborative clinical commissioning group to get agreement for the theory of taking this work forward. Macmillan approached the Commissioning Support Unit to programme manage the project, and that was after we understood that the Clinical Alliance actually was going to cease working. And so it was an opportunity to work with the Commissioning Support Unit, and we agreed funding, and the end result of that was that Macmillan has supported the programme manager with Helen and the coordinator post with Lorraine, and you have already met Helen and Lorraine earlier today, and Helen's going to speak after me. So we agreed funding, and Helen actually came into post from January and has been undertaking a lot of scoping and mapping of what the issues are. So really, what does all of this mean? So we've got lots of opportunities. For Macmillan, this is a very different approach for us, because historically what we've tended to do is we've pump primed and supported an initial post or different posts as part of a team. But this is about a different way of working. It's about partnership and co-creation, but it's almost like, well, we haven't got the answer, you know, this is our opportunity to say, well, what are the issues? How do we move forward with this? And the scoping will help to inform that. And the thing about this as well is that the first year will inform the second, which will inform the third. And I don't want people to think that Macmillan we know what all the answers are, because we don't. We're working together with you to understand what we can do and how we can improve things. There's an opportunity to learn from what works well, and also to transfer that learning. An example of that is that at the moment Macmillan is funding the rehab therapy team for brain and central nervous system. However, we have Hannah, who you're going to hear speak, Susie and Daphne in post, a physio, an OT and a rehab therapy support worker. However, they can't provide a service for the whole of the area, and we've got other people from York and different parts across the patch and North Links and Goole. But how can we get that learning and that understanding across? Because we know that we aren't going to have, you know, 5 different rehab therapy teams that cover the area. So what can we learn? How can the teams work together to provide a source of specialist information? Maybe do joint visits together, initially with an OT or a physio in the community, and then think, well, how will that work for the patient and the family? We want to be aspirational, and this is our opportunity to think about, you know, different ideas and think, well, actually, you know, let's think out of the box and let's use an opportunity to say, well, this has worked, but actually we could do this, and it might be something that's quite a small change, but would relate possibly to further learning and development, or actually think about what Macmillan already has got in relation to the offer in different things. An example of that is we've got a tool that has been developed in primary care that is a decision-making tool that helps GPs to diagnose when a patient who is sitting in front of them describing things might need to be referred because they might have a cancer. There are, at the moment, there have been 6 different pathways that have been looked at, and brain and central nervous system tumours are on the next group to help GPs to diagnose brain and central nervous system tumours. We've got different access to services dependent on where the patient lives. You know, obviously there's an issue in relation to whether you live in rural North or East Yorkshire, or even the significant impact that travelling across the Humber Bridge has for patients who live in Scunthorpe and Grimsby. But what does that mean for patients and their families, and what do we need to do to consider in relation to that? Access to neuropsychology and psychiatry. These are really fundamentally very important to patients and make a significant difference in their experience. And Catherine is going to speak later on about her experience of being a neuropsychologist. And the patients have told us the difference that having access to psychological and emotional support and how that has helped them to cope with significant things. In the patient mapping events that we had, some of the people talked to us about their experience of being a parent and how Catherine has helped them to cope with talking to the children about having a brain tumour, and the understanding that relates to maybe their personality changes, or the fact that they're a lot more irritable about things, and you know, they aren't able to play with the children in the same way because they get quite irritated when the children are excited. And the other aspect in relation to psychiatry is that when we've gone around and talked to the primary care clinicians, one of the things that was identified was that maybe having access to psychiatry services would make a significant difference. This was also mentioned when we talked to people who actually delivered services out of the local hospice, because sometimes managing patients who either were quite manic or were very forgetful or actually needed to have more support, access to having psychiatry and helping manage those symptoms and those issues would make a significant difference to the clinical services, but also to the patient and the family. And access to information and support services. One of the things that the patients have told us so far, and their carers, is that, you know, what's normal? What isn't normal? If they were given more information about, well, what to expect, and, you know, well, actually you will be tired for a significant period of time, or actually, as you've said, Ali, you know, what becomes your normal? Because you won't be the same person as you were before you had this diagnosis. The other thing that helps in relation to information and support is that people need information so they can make decisions, and they know where to go. Even if they forget what they've been told, they know that they can go back to the clinical nurse specialist, or they can go back to the consultant. And the default for a lot of the patients that we actually talked to was to go back to the clinical nurse specialist, and they talked in a very positive way about the difference that people like Louise had made in their life, because they could go back and say, I'm not quite sure if this is something that I should worry about, can you advise me? Other opportunities are about using the patient experience and user involvement. And the thing that fundamentally will make a difference in this is that historically what we've had across the patch is that we've used anecdotal information. You know, the clinical nurse specialist might have said that this is an issue, the consultants have said I'm really a bit worried about this, and you know, patients are telling me that they can't access support when they go home, or you know, the things that they might be worried about. And the thing is that now we've got such an excellent opportunity to talk to patients and families and see what the significant things are in their life, what works for them, what makes this an easier experience for them at very challenging times. We know that there are low patient numbers and the treatment for the pathway is very expensive. But I do think that there's a real opportunity. In fact, although there are low patient numbers who are diagnosed with this cancer and brain tumour, what can we learn from a shared approach with the stroke pathway, with looking at the pathway and managing patients with brain injuries? I think there's a real opportunity for us to work together and to have ideas, and certainly Dr. Salawu, when he talks about his experience of rehab and working with patients who have different diseases, you know, why don't we look at enablement and look at what the symptom is and what the problem is, rather than say, oh well, we can only do this because you have a brain tumour, or we can only do this because you've had a stroke. I think there's such an opportunity for us to share and just bounce ideas and share expertise and learning. We need to take really big leaps to get primary care and secondary care and the communication pathways to be much improved. And I think there's a real passion and a desire to do this. We recently had a medical dinner in Hull where we invited some of the secondary care clinicians and GPs from primary care, and there was a real hunger for the opportunity to shadow each other and to really learn what people are doing. I put this as challenges and opportunities. There is late presentation of patients, often through different emergency pathways. This often results in a lower one-year survival rate. We know that maybe in a GP's clinical practice, they may only ever see 1, 2 or 3 patients in the whole of their experience. Also, the patients present in a very different way, and that can be very challenging, because if the person comes and sits in front of the GP and says, I don't quite feel right, there's something that I can't describe it, that's really quite challenging for the GP to understand and to make that leap and think, well, you know, look at what else might be happening. So we do need help for the GPs in helping to manage and refer patients in. There is a very different experience across referral routes across the area. Some GPs have direct access to MRIs. Some patients, maybe if they come through another area, the GP isn't quite sure how to refer the patient. Do they come through neurology? Do they go on a 2-week wait? So I think that's something that we could definitely look at. And there's also a significant experience for the patients in relation to the different diagnoses that they have and how that is managed, and the difference that there might be for people who have a benign tumour and people who actually have a cancer or a brain tumour, and how that is managed. And I think there is significant opportunities for us to look at in relation to that. I've had my red and my yellow card, so I'm coming to an end. I hope that we have the opportunity to discuss some of these issues. I know there's a great passion and desire for us to take this work forward, and this is, you know, another step forward in relation to that. So I'm going to stop talking and I'm going to hand over to Helen, who's going to give you more information around what we've found out so far. And thank you very much for listening.